The issue I have to cover is cholangioscopy, and of course we don't have anything to do with lymph nodes. So we take care of the inner lumen, as you have seen in the live case before. Here we are. Thank you. And the question is, as compared to the conventional methods with ERCP and brushing and biopsy, etc., what does cholangioscopy bring? In general, you know, the history is, we all know mother-baby cholangioscopes, and it's a kind of clumsy, very cozy here, a lot of people close to each other. Some modifications with the short-axis cholangioscope by Dr. Frimberger, that's one type. The other type is the direct cholangioscopy, where you try to maneuver a slim scope into the common bile duct, and then you have a very nice image, and there are also modifications like with balloon anchoring, which was there intermittently to be able to pull yourself in. In fact, in daily practice, when you said during an ERCP, let's do mother-baby, the reaction was kind of this: oh no, please not, it's 2 o'clock in the afternoon. And let's do direct cholangioscopy. That was actually done by a few aficionados who were probably very good, but the others didn't get the scope in, and this was not a broad-based solution. The situation dramatically changed with a new scope, which had some, of course, technical advantages. It could be, as you have seen, used by one person, and it was also very well marketed, actually, so everybody is very happy, and I've spoken to people in Germany who were proud to have done the first spyglass in the city of X. So, what about results of this new scope? Of course, we already have meta-analysis. We don't have prospective studies, we don't have randomized trials, but we have meta-analysis, and it works as do the other cholangioscopes for biliary stones. That's not really our topic. It also works for strictures, another so-called meta-analysis with excellent sensitivity and specificity. And if you go into a more recent paper, which in 2019, which summarizes sensitivity and specificity, you see that, of course, this is very good, but some other multi-center, serious single-center go down to the values we already know. What's really miraculous is that now visual impressions comes into play, and visual impression is actually much, much better than histology. The question is, can you really use that meaningfully in clinical reality and daily practice? If you try to get a histology, it's negative, but you say, I swear, and I know it, and it's my visual impression counts. A very interesting question, not solved yet. So in the assessment of the single operator cholangioscopy, we are clearly in that period of assessment on a scientific basis. Should we have more cholangioscopy? Perhaps. There are, of course, pros and cons, not only for strictures, but perhaps also for other indications. A little bit more. You can say, okay, who cares about X-ray? Who does upper and lower GI X-ray? That was 30, 40 years ago. Endoscopy has replaced it. Why not in the biliary system? You could save radiation and you could improve outcome. The cons are it's very expensive. It's not sure that we save radiation, maybe, and it's not sure at all whether we improve outcome, because we're only going for accuracy. Of course, there is potential, and you can fantasize what could be done, perhaps. So there are even people saying, well, we can improve cannulation. It's hard to imagine with a big scope, but perhaps somebody develops a little scope, and when you try to maneuver a stricture in the GI tract, you take a small scope, perhaps you can cannulate, but that's a wild fantasy for the future. Of course, you can inspect and biopsy any disease. Perhaps the accuracy is better. You can check after therapy. Whether it makes sense, I don't know. Whether you check for small residues of stones after crushing them. Whether you can tumor therapy. And there is also a dream of ERCP without X-ray in the majority of cases. I'm not sure Whether that really applies here are the radiation dosages of ERCP as compared to interventional angio and the previous generation abdominal CT. This has gone down in the meantime. So I think one ERCP with X-ray, average one, is maybe not so harmful for the patient. At the end, it's the outcome, I think. So the question is, and this is the type of study we have to do, does it change the outcome if we treat more simpler stones, not the difficult ones? That's without doubt by single operator cholangioscopy. If we check after stone therapy, could we diagnose more cancers and sclerosing cholangitis? Nobody knows. Can we guide tumor therapy, etc., etc.? And actually, if we do trials, preferentially randomized trials, outcome should be the main parameter and not accuracy. Because the question is, what's the consequence? And in determinate strictures, you could make an intellectual experiment and think what happens. So a 70-year-old man with painless jaundice and a suprapapillary stricture like that versus a 40-year-old woman with cholecystectomy, cholangitis, and mid-CBD stricture. So this has a priori 95% likelihood of being malignant, and this has a very high likelihood of being benign. So is it necessary to take a biopsy in the two conditions, and does it change outcome? Even more difficult in hilar stricture, there is a likelihood for malignancy which is not 100%. We know there are inflammatory strictures, autoimmune cholangitis is an issue. So what happens if we have a stricture like that? It really depends on the outcome. Does it make a difference whether malignancy is proven and we have a surgical concept, and malignancy is not proven and the same consequences are there because we say we don't know and better operate on the patient, younger patient, etc., etc. It would make a difference if there are different paths, and let's assume the tissue diagnosis is 100% accurate, which it never will be, but let's assume that, then maybe we can save 10, 20% of surgeries if we can really prove reliably that the strictures are benign. If we treat them conservatively, the success rate may be 70%. So at the end, in case of failure, surgical repair may be considered, let's assume 30%. Perhaps that's too high. So that at the end we have 93% and 7%. So the outcome is influenced to a very limited extent with 100% accuracy. And of course, if accuracy goes down, it gets more difficult, because then we have the same figures, and among those, 3% are benign and 3% are miscancers. So this gets very difficult, but that's what we really have to know at the end of the day. Do we benefit in our decision-making? And the studies are difficult, but I think they should be done in that direction. So will there be more cholangioscopy with strictures because it's much easier now? Yes, likely. Perhaps it's the marketing. But it's also the costs, of course, and we have to weigh the clinical benefit with regards to outcome with the money. And if the money goes down, then it will be easier for all of us. Thank you.